7:30, and we said we were going to start on time, so we will kick things off, and hopefully more people will join us as we go along. My name is Mukhtar Ahmed. I'm a surgeon by background, colorectal surgeon, so a bowel surgeon. My involvement with this group was spurred by the COVID-19 pandemic, where this group was convened by Dr. Sadia, who you'll hear from a bit later. Our first priority was to support medics, particularly, and other healthcare workers in Nigeria with protective equipment. But I'll let my colleagues talk a bit more about that. I just wanted to open by explaining why we chose surgery or safe surgery as the topic for the 9th edition of our webinar series. You know, as we all know, surgery is one of the main reasons for outward health tourism from Nigeria, and there's a myriad reasons that that people quote or put forward as their reasons for leaving Nigeria in terms of seeking healthcare abroad. There is no question that we have many talented surgeons in Nigeria, and we have never doubted the skill of our colleagues in Nigeria, some of whom you'll hear from today. As we will hear from our presenters, it is not just about the surgeon, it's about the team, and it's about the whole system around him. So what we're looking to do today, in a nutshell, is to hear about the principles, of safe surgery, the guidelines from the World Health Organization, and hear from our panelists and our discussants how those principles or guidelines are adhered to, what the challenges are, what applies in our environment, what doesn't apply, and how we can work to help improve the safety of surgery in Nigeria. So without taking up more time, I'm going to introduce my co-moderator, who will take things from there, and we'll switch between us for a while. So my co-moderator is Dr. Femi Sani, who is a long-time friend of mine. We've been friends for quite nearly 30 years now, and went to medical school together. Some might wonder why a psychiatrist is co-moderating a webinar on safe surgery. But some of you would know, but many wouldn't, is that Femi has, for a long time through his charitable foundation, organized free surgery outreach programs in and around Ogun State, where he's from. And he's got a unique insight from that perspective of being a non-surgeon, but seeing the challenges around making surgery safe, because surgery is a relatively risky thing, and particularly when you're offering people a free service, there's a lot of pressure on you to make sure that you're not causing harm. So it's something he's passionate about, which is why we're co-moderating this together. So I'm going to hand over to Femi for a bit, and then I'll come back to introduce our presenters.
Right. Thank you, everyone. Thank you for joining us for our 9th edition of COVID Nigerian Medics webinar. Mukhtar, thank you very much for that introduction, kind words. I'm happy to be here with you today. Thank you for inviting me to do this, even though, as you rightly said, I'm not a surgeon, but I've had some experience in providing support for our people back home, trying to provide free surgical interventions through help from our colleagues, our old classmates, people like Dr. Mutalib, which is, I'm very happy is going to be with us today and share his expertise as well. Without taking much of our time here, because my own duty here is very limited. I'm not an expert, so I will let the people that will do the talking and the insights into what we're discussing today to come on board as soon as possible. But before we do that, I'm going to introduce someone that's very special. When I mean very special, Dr. Sadiya Gumi. She's a consultant pediatrician, and what she's done is why we're here today. She is our convener for COVID Nigerian Medics. She brought us all together by the virtue of the fact that she believed in Nigeria, and she wanted us to have a platform to provide support for our people back home when we're faced with that pandemic, and then we're struggling to get protective gadgets and protective garments and appliances back home. So I'm going to let her talk and give her own a brief historical overview of COVID Nigerian Medics and the journey so far. I'm not sure if she's going to have enough time to talk about our new project, and I call it our new project because I'm also very passionate about it, is how we're trying to migrate this to having a very formidable organization called Concerned Medics Foundation. Dr. Sadiya Gumi, I'm handing over to you. Thank you. Take it on.
Thank you, Femi. Thank you. Right. So I didn't know I was going to give a short history of that, but I will try and start from somewhere. So in April, just like everybody, when all this COVID actually just started, and I was actually just in my office doing my admin work, and then a message came up on my phone, and that was a breaking news. And I looked, and they said a colleague of mine that I used to work with had died of COVID. And that really shocked me because, you know, all the time you hear about COVID and you hear all the numbers going up, but I never put a name to a face, you know, someone that had died of COVID. And I just sat there and started crying because this was a very close friend of mine, a colleague who we've worked like 2 years, and I knew his wife and his daughter and everything. So I just felt so helpless, and I called my colleagues and told them, you know, I can't stay anymore. I'm going to go home. So just when I got home, I started thinking, you know, what are we going to do? Because I was so worried, like this, my colleague is here in the UK with all the PPEs and everything going on, and what happens to all the doctors in Nigeria? So something just said, maybe just create a Facebook page. I think I was just helpless. I didn't know what to do. So I just started this Facebook page and I just called it COVID Nigerian Medics. And immediately quite a lot of people joined. And in the process, you know, we started discussing about, you know, just topics on COVID. And then one of the doctors on there, I think there was a video that was posted by, I think, Hadiza, regarding one of the surgeons from Kano was doing some face shields locally. And then we said, oh, you know, well, if they can make face shields, at least maybe we should support him to make more. So that's how we started. We got a steering group with myself, Femi, Mukhtar, Emeka, Hadiza, Shema'u. Just remind me again, I can't even remember now because I'm a bit nervous, yeah. So anyway, we started that, and then, you know, we were able to contribute money and started making face shields, and, you know, that's just how it all started. And then we thought, well, it might be a good idea to do webinars also. So since then, we've been kind of choosing topics that are related to healthcare and improving it in Nigeria. And really, the platform is more of collaboration rather than us thinking, oh, you know, because we're here in the UK or in America or whatever. So it's really like we've gotten quite a lot of feedback from people back home, and they've helped us. So like the webinars are really about collaboration between us and, you know, people that are at home. So from then on, we thought, well, if COVID ends, what are we going to do? We can't just allow it to just die off. So we decided maybe the best thing is to actually make it a bit more official and register it. And that's why, you know, we've gone ahead and registered it both in the UK and in Nigeria, and we called it Concerned Medics Foundation. And actually, we're hoping to do our big launch in July. And I'm really looking forward to all the doctors in Nigeria and here and even Africa. You know, it's not just Nigeria. Because, you know, if we collaborate together, then we can achieve more. So I know each one of us have got their own little, maybe, what do you call it, charity work they're doing. But also, we're looking for collaboration with other charities, and, let's just work together and see what happens. So here we are. This is our 9th series. And today we're talking about, you've already said the topic, I think, but we've done so many other topics. We've done on brain drain, we've done on national health insurance, we've done on mental health. So we're always looking for topics to do. And yeah, thank you guys very much. I don't have anything more to say. Thank you. So I'll hand you over to Mukhtar. Thank you.
Thank you very much, Nadia, for that introduction. We're now going to go straight on to our presenters. And first up, I'll introduce them both, and then we will start describe the order in which they're going to speak. So in terms of who is coming up first to speak is Dr. Ore Bajomo, who's a general surgery registrar in the Northwest region of the UK, working at the Royal Liverpool Hospital currently. And she came to my attention through Sadia because she'd heard her speak at a previous webinar and felt she was quite passionate about global surgery. Like us all here, she grew up in Nigeria and has a passion for improving healthcare in low and middle income countries like Nigeria, and has participated in several global surgery meetings. And she's particularly interested in the ethics of global surgery partnerships, and she'll probably touch on that when she talks. And looks to develop that role and to use those partnerships to help improve surgical safety in the growing field of global surgery. So I'll call her to speak first, but first of all, I'll introduce our second speaker. So before I introduce our second speaker, I'll just say that that Dr. Bajomo is going to talk about the WHO safe surgery guidelines. And we thought we would anchor this discussion around something that everybody agrees with. Everybody agrees the World Health Organization sets the standards for healthcare in the world, and that's what we aim to achieve. And we should anchor our discussions around these guidelines. So she will start with that, but I'm sure she's going to put her own tilt to that title. And then coming up after her, because we thought would lay the groundwork. First, our second speaker is Dr. Adewale Adisa, who's a reader in the Department of Surgery at the Obafemi Awolowo University in Ile-Ife, Nigeria, and a consultant general surgeon at the Obafemi Awolowo University Teaching Hospitals. And he is a general surgeon like me and has performed hundreds of keyhole operations, laparoscopic surgery for those who are in surgery. He has a lot of interest in surgical education, in global surgery, and increased access to minimal access surgery, which again is another realm of making surgery safer, is one of the aspects of reducing, for example, surgical site infections, and I'm sure we'll hear a bit of that. And we're keen to hear his experience of trying to improve the safety of surgery in our environment in Nigeria and what the challenges are. So we thought it would be a good lead on from Ora's presentation. And we have a panel of discussants, but so we don't, everybody doesn't forget, or for the benefit of those that might join us later, we'll introduce our discussants after we've taken the presentations. We'll give a brief summary of the presentations at the end, but we'll take questions after we've heard from both our presenters. So over to you now. All right, the floor is yours.
Thank you. I will just share my screen. Thank you for having me. It's a pleasure to speak with all of you. It's wonderful to hear about this group and all the work that you've been doing within the COVID context and even beyond. It's amazing to hear that a lot of people are doing so many fantastic charitable things. As Mr. Ahmed mentioned, I'm very passionate about improving access to surgery. I think that until we ensure that safe surgery is a universal right, then we have work to do. I think that there have been strides made across the world, and I think that there's a lot of room for bi-directional learning, especially with sustainability and in terms of improving healthcare, surgery specifically, but not just for people in high-income countries teaching low-income, but also the other way around. I think that there's a lot to learn. And so today, I hope that I can just shed some light on the WHO's safer surgery guidelines from my perspective as a general surgery registrar with an interest in global surgery. So today, my presentation, I've spoken a little, I'll talk a little bit about what the guidelines are, but more interestingly, I've dug deeper to try to understand the application of these guidelines across different countries, but not just the application, the challenges that have been faced by different countries when they've tried to apply these guidelines, and why these challenges have been raised. You know, it's very easy for anybody to go online and read the WHO guidelines, and it's easily accessible. And as you'll find in my slides, it's clear that a lot of people know about it, but it doesn't seem to be working across the world. And it's interesting to dig into why, and whether actually it is the right thing for us to be doing, to be trying to apply principles that have been seen to work better in high-income countries, in low-income countries as well. I'll just get onto my slide. So what is safer surgery? Safer surgery is essentially a set of guidelines from the WHO through which they formulated a checklist in 2009. Importantly, these guidelines are actually formulated by participants from low, middle and high-income countries, because the WHO sought to make sure that this was a universal checklist. It didn't want to just make a checklist that would work for countries like the UK and the US, and then you say, oh no, it doesn't work in low-income countries, and we don't know why. It sought advice from people who work all over the world to try to make sure that it would be applicable in local contexts. And you could design it to fit whatever circumstances were applicable in all the 6 regions of the WHO. It was the aim of it was to make a concise document that was focused just on killer steps. And what they did was they came up with recommendations of things that you needed to implement to ensure that surgery was as safe as possible. And then they narrowed this down to what they call the killer steps. And those were the things that were seen to clearly change the outcomes in mortality or morbidity of patients undergoing surgery. So it was trying to say, look, these are the many issues in surgery. What are the main things that we can change to actually improve the outcomes? And these were steps that were found to be applicable prior to induction of the patient, prior to anesthetic induction, prior to skin incision, and prior to leaving the OR. So it's been classified into 3 different categories of steps that are important to recognize. Moving on from that, why do we need this? Why is this important? Is it even applicable anywhere in the world? Is it applicable in different parts of the world? So I don't know how many people know about the global burden of disease and how much of that is contributed to by surgery. A lot of people seem to think that surgery is a rich man's privilege. A lot of people think across the world generally that surgery is something you can afford to do when you've taken care of your other health issues, which is one of the reasons why a lot of global health expenditure is spent on infectious diseases. There's a lot of campaigning about HIV, AIDS, malaria. A lot of that is out in the world, but not so much surgery. We don't focus on surgery because we think that surgery is a luxury, whereas actually 30% of burden of disease worldwide requires surgical care. And that begs the question, why don't we focus more of our funding on it? That's a whole different discussion entirely, but it's just one of the reasons why this WHO checklist was developed, because it recognized the need for an improvement in surgical care in order to improve healthcare worldwide. And it's been found that actually improving safer surgical delivery and anesthetic delivery can avert up to 16.9 million deaths a year. And actually lots of studies have found that up to 10%, there was an up to 10% death rate from major surgery in developing countries, and even up to 22% in industrialized countries where they found major post-operative complications. So this issue was found to be worldwide. It wasn't just specified in certain continents. It was all over the world. There was a problem with the delivery of surgery. Interestingly, nearly half of these issues were found to be preventable. So that begs the question, why aren't we doing those things? Hence why this checklist was brought about. Has it been effective? Does it work? Haynes et al. Published a paper which found a 47% reduction in death. So this was a global worldwide assessment after the implementation of the surgical checklist, and nearly half of these deaths were prevented by the surgical checklist. So it's clear that actually, if we say that half of the deaths and complications that we find in surgery can be prevented, and then we implement a checklist, and then half of them are reduced, then it's working, surely. And then it also shows a 36% reduction in in-hospital complications. So clearly it works. I'll go into briefly some of the principles of safer surgery for the benefit of anybody in the webinar who's not a surgeon, just to give you an idea of the kind of things that the checklist highlights. So first of all, making sure that we're doing correct surgery on the correct patient, on the correct site. I'm sure we've all heard of stories where somebody was supposed to have their left kidney taken out and the right was taken out instead. It does happen. It still happens across the world. And that's one of the never events. That's one of the sort of unforgivable errors in surgery, in the sense that it's easily preventable. And that's one of the first things that the checklist seeks to highlight, to address. Next, the delivery of safe and effective anesthesia, and basically just preparing and thinking ahead, if we did have airway loss, what can we do to address that? If we did have high blood loss, are we prepared to be able to manage that? If we had an allergic reaction, what can we do to minimize the risk of this, or surgical site infection? A lot of us have, I'm sure we've heard about situations where a patient has gone home and they had a swab or a sponge left in them. Again, this is one of those things that we really shouldn't be dealing with in 2021. It's cases that we've become aware of. It's things that we can implement steps to reduce the chances of happening, making sure we have effective team communication, and also making sure that we're surveying and improving our surgical systems within hospitals, within countries, within cities, towns. So next up, I'll talk a little bit about the global uptake of the surgical. Yes.
Sorry, can you just slow down a bit? Some people are saying you're too fast.
Oh, I'm sorry. Okay, I'll slow down. And then if you have any questions, I can go back into them. Just to go back to the last slide, I was talking about the different principles of safer surgery. And here they are. I'll perhaps leave this slide on a little bit if some people wanted to have a read of it. Essentially, it's talking about the general things. These would be defined as the killer steps, the things that we can take steps to address and prevent the recurrence of, and improving outcomes in patients' mortality and morbidity during or after surgery. So I'll talk a little bit about the global uptake of the surgical checklist. So lots of studies have been done to find out how far reaching this checklist has actually gone. And an interesting paper I was reading whilst preparing this showed that countries with lower HDI, which is essentially lower income countries, had about a 30% uptake of the checklist versus countries with higher income, classed as higher income countries. And interesting is some of these were because the checklist was not actually in the official language of the country. So such a simple step, that can easily be remedied, such as translating the checklist. And then interestingly, it was found that in a lot of cases, the checklist was ignored if it was considered a minor case and it thought it wasn't necessary, or whether it was very urgent surgery and it was thought there was no time for the checklist. But what's the point of taking a patient for an emergency operation and doing it on the wrong side, or giving them avoidable mortality or morbidity? The whole point of surgery and healthcare is that we do no harm and we actually improve the patient's the patient's overall status in comparison to when they came to us. So it's important to take these extra steps, take a little bit of time, 3 minutes, to make sure we've taken every step we can to avoid the patient suffering unnecessary complications after their operation. And then the next thing that was considered was negative attitudes. And I'll talk a little bit about what that entails in the next few slides. So some of the challenges that have been found to limit the introduction of the checklist are simple things such as the difficulties faced in implementing new practices in different parts of the world. We have to consider the cultural differences. For example, some countries are quite hierarchical, and one of the main principles of the checklist being able to work efficiently is that every member of the team is able to speak up. So perhaps, for instance, the surgeon in charge wanted to skip the checklist. What the whole setup aims to achieve is that any member of the team can speak up and raise a concern and say, I'm not happy that this hasn't been checked, or that hasn't been checked. I don't think we should proceed until we've fully taken all the necessary steps. Another example, which was quite interesting, is that in Thailand, it's against their culture to mark somebody else. So one of the things that we often do in surgery that has bilateral sides involved, such as orthopedic surgery, is you mark the side that you're operating on. And of course, this is one of the things that you check when you're doing the checklist. So how do you do that when you're not allowed to mark somebody in your culture? So it's making sure that, recognizing those challenges and adjusting the checklist to suit whatever is applicable in that setting, in order to make sure you achieve the outcome. Because at the end of the day, there are many ways to skin a cat. And what we need to do really is to get the benefits from it, not necessarily in order to make sure we follow those rules exactly. And I'll explain what that means shortly, what I mean by getting the benefits of it and how we modify the checklist. Because actually the WHO has recognized the importance of being able to modify this checklist within different contexts, and it has actually provided steps to modify it to suit the relevant context. Some of the other things that were raised as challenges to the implementation of the checklist were limited resources. So some countries recognized that they didn't have, for instance, pulse oximeters to measure patients for anesthetic monitoring. It wasn't as easy to find a razor, which is important in reducing surgical site infection, to shave the area that's being operated on. Being able to sterilize the equipment, having adequate staff, having access to antibiotics, things that would generally affect the patient's outcome were limited in some cases. So one of the most interesting slides that I really wanted to focus on was this slide, which talks about the application of the checklist in several countries / parts of continent. In East Africa, so there was a study done in East Africa which showed quite a low uptake of the checklist in 5 East African countries that were surveyed. But it wasn't because people didn't know about the checklist, it was because it wasn't available. And this begs the question, if you know about the checklist and it's not available, perhaps because you don't have a printer, why haven't we come up with, say, perhaps a laminated version of the checklist that we can put up on the wall and rub off every time we've done a patient? We go through the points that we need to check off and then rub it off. If we don't have access to a printer, we don't need a printer. It can be written on a blackboard. The whole point is we know about it. Why aren't we using it? In Rwanda, one of the papers that was studies conducted in Rwanda about the application of the checklist found that actually it was variability of the resources that were available, not necessarily not having the resources. It's just that they were different to what was prescribed on the checklist. And again, this begs the question, can we go back and modify this to suit our specific context in order to gain the benefits that we're looking for? In Madagascar, a study was done that showed sustained use of the checklist in 74% of hospitals that were surveyed. And some of the issues that were raised were challenges in change of practice. So being able to gain buy-in from the local collaborators and making sure that people that you're working with recognize, the benefits of the checklist and how to implement it. And then in Moldova, in Europe, they found sustained improvements, specifically because in Moldova, they actually modified the checklist. So they used a low resource setting implementation strategy, which showed that when they modified it to suit their context, it worked for them and it had sustained improvements. A paper done in South Africa showed that the reason they weren't able to implement the checklist was because of time-related issues. So thinking, oh, we don't have enough time to do this. This is too much of an emergency. But if you start doing a case and you don't have a backup plan if the patient were to bleed, how much time do you spend trying to resolve the problem when actually you could have prevented it in the first place? And buy-in from team members. And then there were several studies done in Nigeria, one of which showed 63% uptake. And actually it was assessed that there was a very high knowledge of the surgical checklist within Nigeria. Some of the challenges that were raised in those papers were lack of assertiveness from perhaps other team members and not feeling perhaps comfortable raising concerns if whoever was considered the team leader was not engaging with the checklist. Some participants in the surveys found that they did, commented that they didn't feel they were sufficiently trained, or they didn't feel as though they had enough time to undertake the checklist. Moving on, I've been talking a lot about modifying the checklist. So I've just put a picture on here of, there's a website, and I can provide this at the end if anybody's interested. I can provide a link to it, which I found online, which shows an implementation guide for the safe surgery checklist. And what this does is that it highlights the various points that you need to address to make sure that if you are modifying this checklist, you do so in a safe manner in order to gain the necessary outcomes that you're looking for. So the 7 things that it says that it aims to achieve is that your checklist remains focused, it remains actionable, it's collaborative, it's brief, that it involves verbal communication, it's tested, and it's integrated. So if anyone was interested at all, this is quite a good document in order to look for a way to make it more applicable to our specific environments. So some questions that I think would be interesting to address at some point, I don't have answers to, and perhaps some of our discussants might be able to shed some light on this. Will this work in Nigeria? Will we see the improvements that we've seen in other parts of the world if it were to become 100%, 90% implemented across Nigerian hospitals all over the country? I'm sure I've read in papers that clearly it is more implemented in certain parts of the country than others. But if we were to get 100% coverage across the country, will we gain the same benefits? How do we actually implement it? What do we need to modify? Do we need to look for sustainable ways of modifying it? Do we need to look for versions that don't involve printing off a piece of paper every time? Do we need it on a blackboard? Do we need it on a whiteboard? What can we do to really make sure that this is sustainable? And more importantly, along those lines is how do we gain buy-in from local collaborators? So, as a group, perhaps if this was something we decided to focus on, what steps are we going to take so that the people that we're working with actually take ownership? Because it's very important that we're not just prescribing methods of improving healthcare. It's important that we work in collaboration and actually work together as a team to improve healthcare by addressing challenges and working together to look for solutions to those challenges. And then finally, an important part of any implementation strategy is measuring the outcomes. How do we assess that what we've done has been successful? Go and make sure we're improving the quality, go back, address our whatever challenges we've had, and then continue to improve that process until we have the desired outcome that we're looking for. So those are some of my references. And thank you. That's the end of my presentation.
Thank you very much. All right, we'll go straight on to, in the interest of time, to Dr. Adisa, whom I had introduced earlier, who's a consultant surgeon at OATH IFE and a reader in surgery. So over to you, Dr. Adisa. Thank you.
I'll first like to start by thanking everyone for joining the call, and also to thank everyone in the foundation for the good work you are doing. I was very impressed hearing the things that the foundation did during COVID, as well as the things that you're already proposing to do. I will also say that this is the second time I'm presenting after Ore, and I think in quite a number of my presentations, I found that presentation always very, very good to follow, because probably after now, I'll be telling every other organizer of webinars to make Ore present before me to make my job easier. Ore was very brilliant. And I'll be speaking about towards safer surgery in Nigeria, and Ore has touched on virtually every slide that I have to share with you today. I hope you can see the full screen. Okay, so I work at the Obafemi Awolowo University, Ile-Ife, and incidentally, the university is 60 years old this year, and we're celebrating. To go on to the subject for today, the study I put up here is perhaps the one with the largest series published about elective surgeries in Nigeria, looking specifically about postoperative complications. This involves 79 hospitals from virtually every state across Nigeria, but it included only hospitals with intensive care units. That tells you that this is probably a survey of the best we have to offer in the country, and reported 18.5% complications from almost 1,500 elective surgeries. Now, there was a huge case mix here. So we're talking of very simple cases and also involving complex cases. The 1.5% mortality rate recorded in this study, which is actually the Nigerian extraction of the ASOS study, which is quite popular, the African Surgical Outcome Study, it's exactly double the mortality rates reported for elective surgeries, even though the case mix may actually be different, making it a bit difficult to generalize. But it tells us that there are a lot of things we can actually improve upon in terms of surgical outcome. I'll also say here, I'm the Nigerian Deputy Hub Lead for the Global Surg Collaborative. And we recently did a randomized control trial across the world, and my hospital recruited the largest number of series for that trial, the Falcon trial, and the study is about being published now. But I'll just share a little experience regarding the issue of using surgical checklist. And I noticed that a particular section of the hospital, a particular unit involved in surgery, the adoption of checklist in that unit was like 10%. And this is a unit that deals with emergencies. Okay, I can be plain and simple here, talking about cesarean section. And you ask every surgeon and perioperative nurse, why haven't we used checklist? Because it's required in the Falcon trial for you to document whether it was used or not. It's not, you're not compelled to use, but you have to document whether you use. And every surgeon will tell you, we were in a hurry. But when you go on to upload data to REDCap, you discover that you were in a hurry to operate a woman who had a premature rupture of membrane. You wanted to quickly do a cesarean section to save the child and the mother. But at the end of the day, you didn't use the checklist. And then in putting the record online, you discover that along the line, we've forgotten to administer antibiotics in a patient that is a septic case. So the adoption of these things, as simple as it is and as Ore has highlighted, has a huge potential in reducing the complication rate as well as mortality that we record. A lot of procedure-specific complication rates are also recorded in the literature across Nigeria. But apart from specific complications that are published in literature, there are no records of patient-related injuries or accidents. How many patients suffer burns injury from a diatomy pencil? That will probably never be published. We'll probably not have series of how many electrical sparks or wire or accidents or fire we recorded in an operation room in Nigeria. I think we all know this, that major errors, major hazards, major complications do not usually arise because something bad went wrong one day. It's usually an accumulation of different near misses, little steps that we've overlooked, little violations, and little mistakes that probably on a good day, we still find a way to get around and no complications were recorded. But a day comes that all this add up together and then we record the major catastrophe. We scream. To err is human, we all know, and the WHO surgical safety checklist that Aurea has beautifully highlighted. In Nigeria, she presented a study that I'm also aware of, conducted by Nigerian anesthetists, reporting over 90% awareness, reporting over 60-something% adherence and use. But I must say that many times when you're conducting a study, then the usage possibly gets high because everybody is aware that somebody is looking out for this for the purpose of a study. And I'm very sure that the usage is probably much, much lower than what has been published in the few series that are available. There are also, apart from the WHO checklist, there are also procedural specific checklists that we also need to be looking into, as well as institutional protocols to enhance safer surgery. In Nigeria in particular, I'm sorry to use this title, but it looks to me as if we have some ingredients for disaster to happen following surgery. Number one, coming from a place where you can be celebrated for doing surgery under a tree, and politicians and volunteers and everybody come and celebrate that we've done 1,000 of these surgeries, and how about the safety while this has been done? So we celebrate that we do this, we get away with it, and nothing happened. And in many instances, nobody even goes back to check what happened to these patients. We have a perennially underfunded healthcare system is a disaster. My hospital is currently conducting an interview for residents in surgery, and that is probably the first time in 4 years because the current government in Nigeria had played an embargo on employment of residents for years, 2, 3, 4 years. Talking about personnel, not even talking about facilities. Now, you want to do a surgical checklist, and the nurse is asking, has the pulse oximeter being connected to the patient? And then the anesthetist scream at an attendant, go and bring me the pulse oximeter from the next OR. In a tertiary hospital where you'll be sharing pulse oximeter between cases that are running concurrently. And it seems as if not only that, we'll have this disgruntled workforce, people who are on the streets clamoring for hazard allowance, and then you need to sit down, you need to sit this same set of people down and talk to them about safety. Finally, we have a culture, we have a people who are resistant to change. As it was in the beginning, so we want it to be now. This is the way Professor so-and-so used to do a particular laparotomy in 10 minutes. Why are you now spending 5 minutes on a checklist when he will have taken out the appendix? We need to start embracing that. And for me, cultural change is a major driver of improved outcome. The culture we have embraced in our different ORs, the way we have done surgery in the past and how it ought to be done now, there is need for change. This study was published in Implementation Science, talking about the physician's experience of changing clinical practice. I've had the opportunity to speak at different fora, surgical fora in Nigeria, and I find that changing the culture of practice, even if all you're talking about is just, can we take a pause and do this checklist? As what, and I really love this study because it seems to put all the things I've heard into words. First is that everyone complains that practice change disturb the status quo. You want to rush into theater, you want to rush out of it. You have so many other things to do. There are patients waiting in the clinic, and so disturbing the equilibrium of this is how our whole. Number two, the evidence itself and the context. Oh, this is how it is done in the UK. Do you think that can be done here? And we need to constantly bring physicians in Nigeria. Well, this time around, we're talking particularly about surgeons and the surgical team, to realize that the evidence thrown at us calls for us adopting, first of all, taking ownership that this change is for our own good. And then, like Ora said, we can then look for context, how to adopt these safety protocols into our context. It is only when we agree that the evidence is for our benefit that we look for how we can then bring it into our own context. I found these tips for changing culture in an organization published by Sabapathy, and reading through some of these things, you really wonder whether this psychologist should be invited into our OR to do some bits for us. First thing he said is to define what are the values and behavior we are all looking out for. And I highlighted the ones that really speak to me and speak to how we need to bring this change into our surgical practice. We need proponents. Sometimes it looks as if it's the surgeon that is insisting that this thing should be done. Is the one everybody shouts down that his own problem is too much. But we need a lot more proponents. We need guys who are going to step up and say, look, these things are for our own good. Each hospital must stand up and incorporate this. We need to measure the effort. We need to come to say, this we want to adopt. What has it changed? What has it done to us? A friend of mine in Uganda, in the Global Search Collaborative, we met in one of the meetings in Rwanda, and he was sharing with us how he changed the adoption of surgical checklists in Uganda. He presented this to surgeons, and I was saying, oh, I've also done that in my own department, and it didn't change the adoption 1%. But then he went to nurses, perioperative nurses, sold it to them, and honestly, I came back to Ife and did this, sold it to the nurses, and the adoption went up by 60%. So we need to be able to measure what happened before, what happened after. And then he taught all of us that what he now went to do later is to go to their school of perioperative nursing, such that every perioperative nurse in training is not only taught about the use of surgical checklists, but part of their qualifying exam is to examine them on how to administer this. So local things like this can help us a lot. I highlighted also investment, because like Horace said, in my own theater, we went in one day, why have we not been using checklists? And it was that the photocopies of the checklist had been exhausted for over a week, and there's one of my guys, is a consultant surgeon, who has been in charge of making this available. Nobody has told him is exhausted. And so the investment may be as little as making a photocopy, but on the other hand, the investment may be for us to actually provide facilities for safety. If you do checklist every day and you tick the same thing that post oximeter is not available, and you continue ticking that safety step, you are skipping it, then you're actually not adopting, because it's supposed to help you to make a change. So this is one of my last slides, because I just put a few thoughts together. What should we be doing in the different surgical units in Nigeria? Number one, institutional protocols for safety in surgery. There has to be a protocol for each institution saying you must take this and this and these steps before making an incision on a patient. And that protocol has to be owned by departments, by heads of departments, by heads of perioperative nurses, by anesthetists. There has to be protocols guiding the practice of surgery. Like I said, we're coming from a background of a surgical practice where it is done by that big name professor this and that. It is done in that so-called hospital, but they are probably being done just the way the individual or the group concerned feels like doing it, without any protocol being followed. There has to be regular training. There is no point saying that somebody hasn't used something they've not been trained on how to use. Training residents, training nurses, training consultants on the benefits. We have to also audit how many units have adopted this. The units that have not adopted, like I said to you, that I detected during the trial that we just collaborated in. The units that have not been adopting, why have they not been adopting? And then through statistics at them, your unit was not using safety checklist, but so many of your patients had sepsis and somebody forgot to give perioperative antibiotics. So if we audit our system and practices, we do morbidity mortality meeting in many units. We just ended one in my own department about an hour ago. We need to audit our systems and call things to question with the aim not to criticize and shoot down people, but with the aim of improving the outcome of our patients and delivering safe surgery to our patients. We can't
Sorry,
finish.
Dr. Adisa, I know you said you're rounding up, but you're in extra time now, just so we can bring our other panelists in.
So this is my last slide, and
you.
we can't finish talking about investment and good maintenance culture, and also to talk about leadership. Thank you. That's my last slide. Greetings from Nigeria. Thank you.
Thank you very much, and sorry to interrupt. It's just keen that we get out, to hear from our other panelists. So that was a very interesting presentation there, giving us the perspective and the challenges. Particularly good to hear about your perspective on what the barriers are to the adoption of these principles in our environment in other low middle income countries. I will say, for the sake of time, not go try to do a summary, because your presentation and that of and Ora's before yours were quite detailed and easy to follow, even for those who are not in the field of surgery or even in the medical field at all. Just so we can bring in our other discussants, I'm going to hand over to Femi to introduce our first discussant. But before that, just a reminder to put any questions in the chat, and hopefully we can bring back our presenters in to answer some questions and to and to respond to any comments that have been made. So over to you, Femi.
Right. Oh, thank you very much, Dr. Adisa. And all right, I don't mind me calling you Ora. Well done for that. It's a very insightful presentation as well. I'm going to call our panelists. First of all, I'm going to call a very dear friend of mine, Dr. Zainab Katungo. She is a consultant plastic surgeon at the Federal Teaching Hospital in Gombe. Dr. Kitungo was a former CMAC as well. She's got a wealth of experience in surgery. She's going to give her own take on what has been said so far, as well as giving her expert view as well. And then following that, we still have two other panelists to come. So we're going to give them equal time so that we're finishing at 7 o'clock. We start at 7:30. We're finishing at 9 o'clock, and we don't want to keep people waiting. We spent valuable time listening to our previous two awesome presenters. Thank you so much again. I'll call Dr. Zainab to come on board, please.
Just thank you, Femi. Just to add, if our discussants could keep to 5 minutes initially, and then if there's any questions that pertain to their field, we can call them back. Thank you.
Thank you very much for inviting me and the opportunity to be part of this. I'm going to be turning off my video shortly because I need to save on data, or else my internet could just go off if I keep using video. So I'd like to say a very big thank you to the organizers and to the presenters, and then I'll give my insight, particularly safe surgery generally, and then quality improvement and patient safety that I'm so very passionate about. When it comes to quality improvement and patient safety initiatives, it's apparent that the populace, at least in the healthcare setting, are very interested. There's initial good uptake, but there's a problem with sustainability. And the only thing I can see that's likely to solve that is when, according to one of, to use the words of Dr. Adisa, we define some non-negotiables when it comes to quality improvement, patient safety, and then by extension, safer surgery. If I'm to bring my experience, and at the time when the safety checklist became very popular in my hospital was about the time I was head of clinical services in the hospital. And there were people who were very passionate about it, and practically every operating room was using it religiously for elective surgeries. And soon after, I was no longer head of clinical services. I went on leave, and then I came back and I realized it was not being used regularly anymore. And then I decided to ask one day, and they were like, oh, you're no longer CMAC now. People are no longer interested. And I asked, are we no longer interested in the good results? Or was it just being done because I was CMAC? So again, until we define some non-negotiables, we still have a very long way to go. Then again, I remember there was something else Dr. Adisa said, and I related to something I heard from Mukhtar some years back when he introduced quality improvements and patient safety to my hospital. He said he had gone for some interview and somebody was asking him that what was his percentage, I think morbidity, mortality, I can't remember with reference to what surgery. And I was like, if this is part of one, your employment when you're coming in as a consultant, if it's part of your maybe annual performance reviews, okay, so you've done 10 laparotomies, what were your complication rates? If that is not incorporated into the system, I think we're going to still have a long way to go, because irrespective of how many surgeries you do, irrespective of your complications, you're still going to get paid. Nobody's going to say anything if your complications keep mounting, apart from those who keep whispering behind you. I think we still have a long way to go, and this is something that we need to look into. Thank you.
Thank you very much, Zainab, for your insight. And I know Femi introduced you quite well earlier on, but you know, I've admired your passion for improving patient safety, and in a very challenging environment. You know, like our other speakers today and our other discussants, you know, I take my hat off to you. I remember my first visit to Gombe and watching one of your colleagues perform a cholecystectomy with the most minimal of equipment. I think he was using his laptop as a screen because the screen on the stack wasn't working. And I was full of admiration because I couldn't have done it hand on heart. And, you know, the fact that people push the boundaries, even in the most difficult of circumstances, and trying to do it as safely as possible. So next up, I'm going to introduce Mrs. Grace Yakubu, who is a good friend of mine, but also a colleague. She joined us at our hospital in Poole here in Dorset, part of the University Hospitals Dorset, just about 2 years now. Grace has become a valuable part of the team. It's almost like she has always been here, and everywhere you turn, people sing her praises. So Grace is an experienced theatre nurse who has a unique perspective because she trained in Nigeria. She's a very true Nigerian. I'm sure she won't mind me saying origins from Ondo State, but you know, Yobe by statehood, if we say, and married to somebody from Yobe. So you know, you are one of the true Nigerians, and the people that say Nigeria is not one country, you know, Grace is the answer. Grace is the answer to that. I don't know how many languages you speak, and you know, we won't test you today. But and then obviously trained in the public sector in Nigeria, but before she came to the UK, worked in the private sector in actually a very, very good hospital. You know, certainly by standards of low and middle income countries. So she sort of had a gradual exposure to the different sort of levels or realms of patient safety. And we were just looking to hear your perspective, Grace, of your journey, really. What do you think is the key difference or the key obstacles, and your experience here in a few minutes? I think you're mute. Oh,
yes,
yeah, there you go.
Thank you very much, Dr. Ahmed, for inviting me to this banner. Thank you for all the participants. I welcome you to this enlightening and cherished opportunity to learn more about safety in surgery, especially in our country, Nigeria. Yes, like Mr. Ahmed rightly said, I trained in Nigeria, University of Benin Teaching Hospital, and I worked in Benin as a perioperative nurse for quite a while before I moved to Abuja. Yes, in my training, we were trained about surgical safety. We learned about the WHO checklist, but it took time for it to get to the hospital where I worked. We started using the WHO checklist, surgical checklist from 2011. And like all the presenters have said, they presented very nicely, very beautifully, and they encompass all the challenges that we have in Nigeria with regards to observing or using the surgical checklist. I don't have anything to add to that because those were the challenges. But one point by the male presenter, when you approach the perioperative nurses, there was a change. In my place of practice, if you, the perioperative nurse, don't come up to say, we really need to do this, if you have a surgeon who is not interested in it, then you have the challenge. So, but fortunately where I worked, the surgeon is one that was also trained in UK, and we were able together to implement the use of the surgical checklist. But after I left, whoever continues, so it depends on the interest of those persons to carry on with that practice. But it really makes a great difference in our practice, because by the time you take the checklist, that's when the anesthetic will remember, oh yes, I need this other drug, antibiotic prophylaxis for the patient, and then you go get it. Sometimes the sites are not marked. The presenters have talked about challenges with not marking the site for surgery. Things have happened and they will not be published, like they rightly said. They won't be published that, yes, we did surgery on the wrong site. So this checklist actually makes a great difference in our practice, both for the surgeons, for the anesthetics, and for the perioperative nurse. I would really like us to carry this message home and try to enforce the use. like he said, about 60% improvement. If the perioperative nurses stand up to say, yes, we need to do this, and the surgeons as well, those two professionals in the theater, if they are able to stand up to say, we need to continue to use this checklist because it's really helpful, then I'm sure we'll make great difference in surgical safety in Nigeria. I don't think I need to add any other thing. Thank you very much. And I want this webinar, this meeting, to escalate, to reach out to even those who have not been invited. Let the documentary, let it reach out to others so that surgical safety will be improved in Nigeria. Thank you very much.
Thank you very much, Grace. And that's an important point, and it's something, part of the work that we really want to carry forward, stimulate the discussion, but then carry on and spread the information, and hopefully you'll work with us on that. So I'll hand over to Femi.
All right, thank you very much, Grace, for your insightful opinion and views about how things have been since you left Nigeria. And then we're also grateful for the part that you are on board from your conversation, that you are going to join us in pushing this forward. As Mukhtar just said, we want to expand, we want to collaborate with a lot of people, and that's why we're moving this away from just the webinar and having a foundation that we can all work together, not only in Nigeria, but in Africa. And that's why we have a foundation called COVID Concerned Medics Foundation. I will enjoy everyone to try and go onto our website and see what we've got there. There are a lot of resources in terms of educational resources. Some of the things that we've done today will be put there as well. Now, I need to call on the last speaker. He's a panelist, Dr. Mutalib Shobode is a brother of mine. I've known Mutalib since our medical days, and then he's been a surgeon for over 15 years. He's a consultant spine surgeon. He works in the National Orthopedics Hospital in Dala in Kano State. Dr. Shobode, I must say a big thank you to him, because I can still recall in 2016, I went to see him at this private clinic in Lagos, and I was saying to him, I had this passion to do some surgical procedure, just as a way of giving back to the community. And he motivated me. He facilitated our first ever surgical procedure, what we call the surgical outreach, then in Ogun State. And since then, we've been having it every year on the Stadium Memorial Foundation. Anytime we call on him, anytime I approach him for guidance and support, he's always there for us. And Dr. Shobode will give us his own views and his own takes, because he works in a very diverse area. He works in a place where they get a referral from tertiary referral from sub-regions, Chad and Cameroon. And then I'm sure they've seen a lot of pathologies that he's going to talk about his own challenges as well. Dr. Shobode, over to you. Thank you very much.
Thanks so much, Kenki. Thank you so much for the kind words. And I'm always happy to be there to assist the foundation for all the things you do. Thank you, Char. And I want to crave your indulgence to allow me to. Can you hear me?
Yeah, we can hear you.
Yeah, Zainab spoke for 2 minutes and Madam Grace spoke for 3 minutes. So I can take 3 from Zainab, 2 from her, and I add my own 5 minutes. I can speak 10 minutes. So that's okay.
All right, go on.
Good. So, I mean, I won't be the first person to acknowledge the fact that we have an imperfect system in Nigeria and probably in West Africa. But nonetheless, the system is functional, and we need to continue to push the frontiers. We need to continue to push, the administrators, the government to continue to help us. I feel Dr. Adisa's pain, or Professor Adisa's case, I feel his pain, and I understand where he works is not a mono-specialty hospital, and things can be a little tough, to handle in systems like that. And we also need to appreciate the fact that we have different, hospitals in Nigeria operate at different levels. I work in a place where we see mainly orthopedics patients or patients with orthopedics problem, and a few with, needing plastic surgical procedures. For instance, in my unit, I'm a spine surgeon there. My colleagues and I have done quite a lot of surgeries in the last 5 years that I've been or 6 years that I've been in Ghana. We won't say because we don't have everything to work with, we will not operate on the patient. Over 200 million patients. For Kano alone, we cater to the needs of patients from Niger, from Cameroon, from Chad, from Benin Republic, and all over northern Nigeria. Where do you want us to push these patients to? Yeah, we agree that there are so many things we should put in place, but not all the time we would leave the patients because everything is not in place. I'm referring to Dr. Adisa in this instance. I have had my own fair share of complications. There's this saying that if you don't have complications, it means you are not operating enough. But one thing is you must not repeat the time-honored complications. And also, I began to appreciate my teachers when I got to a certain level of my practice. This saying that a good surgeon knows how to operate. A better surgeon knows when to operate, and the best surgeon knows when not to operate. As you grow in your practice, you begin to appraise situations better. You begin to look at the pros and cons. You begin to look at pathology, and you determine the personality of the disease or of the pathology. And you tell yourself, this is not a patient to operate because it's likely to come down with a lot of complications. Okay. But we also need to know that safe surgery does not begin in the theater, or safe surgical practice does not begin in theater. My colleagues in the National Nigerian Orthopedic Association, we held a series of webinars, last year between October, if I'm correct, and December. Dr. Kemi Lawani was part of it. We held a series of webinars on quality improvement and patient safety. I think this ran for about 3 months, and a lot of people benefited from it. And I think this is something we should be doing, continuously. I'm glad Zainab made reference to the fact that Mukhtar was part of it in Gombe, and everybody talks about Gombe, and I think Zainab deserves a pat on the back for that. Now, safe surgery does not begin or end in the theater. It actually begins before the patient gets into the operating room. First, you need to know that you need to ask yourself, is this patient optimized enough for surgery? A patient that is hypertensive or diabetic, have you done all the things you need to do to make sure the patient is ready for surgery? Is the surgery timely? This is very important. I remember when I was at Luke, before, knife for skin is supposed to be 8 o'clock. Nurses resume at 7:30. They start praying at 8 o'clock and they hand over at 8:30. Meanwhile, you have a patient with a ruptured ectopic on the red line. You have a patient with acute abdomen on the red line. Of course, the patient is likely to, you are likely to lose the patient because the surgery is not done in a timely fashion. Now, is the most competent surgeon involved, either as a primary surgeon or as an assistant? This is very important. Is the surgery you are doing evidence-based, particularly with regards to the available facilities that you have in a hospital, as well as expertise? Is the surgeon doing the surgery or the assistant, equipped with the right, skills to carry out the surgery? Because a lot of times, I have seen a lot of patients with all sorts of, constructs in their spine. And I begin to ask myself, where did this person, this surgeon train? Is this surgeon doing this surgery for the first time? How many has he done? All right. How many has he done under supervision? Or they just, a lot of time we end up using these patients as guinea pigs, to learn surgery. I'm sorry to say this, okay, and this shouldn't be at all, because these are our parents, our wives, our relations, and this shouldn't be at all. Is the hospital equipped to handle the case? Is the hospital equipped enough to handle either the intraoperative complications that might arise or post-operative complications, that might arise as a result of the surgical intervention? Do you have the support services as well as the personnel? Have you briefed them enough on what you want to do? These are questions you must. I remember talking to Mukhtar about 2 weeks ago or 3 weeks ago when he was in Nigeria about the need to have a multidisciplinary team. You discuss with these people, with your team, you discuss with them what you want to do, how you want to do it, and what you aim to achieve. Do we routinely discuss with these people, including nurses, physiotherapists, pharmacists, perioperative nurses, and residents as well? Do we discuss enough with them what we plan to achieve with the surgery we are doing? Unfortunately, surgeons in Nigeria go through a lot of emotional and mental trauma just to operate on a patient, whether it's in a private hospital or in a government hospital. You have to think for the supporting staff. You have to think for the implant companies. You need to troubleshoot hospital logistics. And this is very important. And so I was expecting Zainab to talk a lot about this. Troubleshooting hospital logistics is one of the things that, if you permit me to use this word, that will mess up your work as a surgeon. You need to juggle patients' finances. I want to do scoliosis surgery and I need to put 20 screws, and I realize the patient cannot afford to pay for these screws. So instead of putting 20, I end up putting 10 or 14 because that's what the patient can afford. And then finally, you need to cope with patients' relations, particularly the diaspora relations. People like Mukhtar, people like Dr. Ore Ajomoy, I hope I'm correct with your name. You need to cope with all these people. It's not that the surgeons in Nigeria are afraid to talk to them, but a lot of time the pressure is too much. You explain to this person, you explain to the pastor, you explain to the imam, you explain to the community leader, you explain to the Serikin Yorubawa in Kano, and you explain to likes of Mukhtar abroad. This is quite difficult. Then for the WHO checklist that Dr. Ore talked about, I have modified the WHO checklist a number of times.
Network is cutting out a bit there.
Can you hear me now, Mukhtar?
All right, there.
Can you hear me? Yeah, Dr. Ore talked about.
Yeah, you'd cut out a bit, but yeah.
You heard about the troubleshooting bit, right?
Yeah, carry on. We can hear you. Carry on.
I wanted to know if you heard about the troubleshooting bit, where we go through a lot of stress when we do a lot of troubleshooting.
Yes.
All right, I'll let it slide. All right, Dr. Ore talked about the WHO checklist, and everybody picked up on that. It's very important. It's very important, but we need to modify. I needed to modify the checklist to suit my own purpose in Nigeria, particularly in Kano, and I carry it everywhere I go in Nigeria. On the checklist, there is no, I will just give a little story, a short story. I was called to operate on a patient. I traveled from the UK. I met the patient relation somewhere around West Ham. He gave me money. He paid for the surgery. The patient was going to be operated on in a private hospital. An orthopedic surgeon was preparing the patient for me. The patient had multiple osteoporotic fractures of the thoracic spine. I got into Nigeria on Monday. I arrived in Kano on Tuesday. I went straight to the operating room in the evening. Anesthetist was there. Patient was being intubated. I was scrubbing. I looked at the X-ray. They briefed me again. Looked at the MRI. I was ready for operation. I was scrubbing when I saw the anesthetist just struggling. Patient had Addisonian crisis. Well, that was our diagnosis after we lost the patient. They were struggling with the patient. What happened? He said he doesn't know. Everything just crashed. Then I asked, can somebody brief me about this? Someone just came from nowhere. I think the guy that referred the patient said, oh, this patient had been on steroids for the past 6 years, and nobody picked that. So I added it on my own checklist. This patient shouldn't die in vain. I added it on my checklist, steroid use, as well as use of non-steroidal anti-inflammatory. We so often forget to ask patients about this. So if I pick it in the operating room, I do something about it. The patient
Dr. Shobade, thank you so much. I can see that you're very, very passionate. If we don't stop you now, you can go on and on. We have 10 minutes to go. We will give our attendees the opportunity to ask questions from the panelists. And then Dr. Ahmed Mukhtar, I want you to take it from there, please.
Okay, thank you. And thank you very much for telling us. As you know, we've had many of these conversations, as Femi said, we could go on. Everybody's here because of how passionate they are about what they do and the desire to make change. I haven't seen any questions put in the chat. If anybody's seen any, let me know. But is there anybody here that wants to come in? Anybody who wants to put their hand up and contribute? Anybody particularly with a different perspective, different experience? While we're waiting for that, I'll just add, and I saw a comment earlier, which is very important to note, that introducing these checklists and the guidelines, even in the UK, faced huge challenges, and they continue to face huge challenges. In my role as clinical director or head of department, as it would be described in Nigeria, are constantly one of the commonest complaints that I get about consultants other surgeons is their refusal to adhere to the guidelines, and Grace would know this, that we all do it differently. Some of us, for example, part of our own checklist that we've modified in our hospital after a series of losing swabs inside patients, which is described as a never event here, something that should never happen. We added something called stop for gauze, which meant that at the end of the case, before we started closing, that everybody stopped operating to allow the scrub nurse to do their count. Now, it usually doesn't take 5 minutes, even shorter for experienced scrub nurses like Grace. But many surgeons are impatient. They've been operating for 6-7 hours. They want to finish. They're putting their hands on the trolley and grabbing the needle themselves, and that sort of behavior. So even here, it's a human factor. It is not unique to Nigeria. It is everywhere, just so people don't feel like we are putting down what people do in other parts of the world. The difference here, and I think, all our speakers have alluded to this, is that there's this system, the checks are stronger here in that, if things go wrong, the consequences here are quite severe for the practitioner. And that focuses the mind. It's not just the fact that people somehow are more law-abiding here or follow rules more, but there are very strong systems to check, that people adhere to those principles. And there is a very strong judicial system that backs that up as well. So if you're found not to have followed principles and somebody loses their life, somebody will pay a price for it. They might lose their license or they might go to prison. And some healthcare workers have done that when it is proven that they have willfully neglected their duties. So I think it is, it's a few minutes to go. I don't know whether there's any further comments that Ore or Wale want to bring in at this stage to, based on what everybody else has said, if there's anything you want to come in, and particularly again for Zainab, because you spoke for a very short time, and I know you've always been very disciplined, but we have a few more minutes. So if you all want to take a couple of minutes to, to come back on some of what's been said.
Thank you. It's been a very interesting evening. I've learned a lot about things that I hadn't considered. And also it's very nice to see and hear from perspective of people who are actually working in Nigeria rather than reading papers and wondering how much of this is true and how much of it isn't. Just to circle back onto, a lot of the points have been touched on, I think it's important to, as we said, implement it safely. We've seen instances where people have modified it to suit their practice, and it seems that that is working, whether implementation or the actual checklist itself. One of the things that I didn't mention was that one of the papers I read, which had been successful in the lower resource setting, which was Moldova, they had an implementation team. So I think if perhaps anybody was looking to take this forward, if you were to read that paper and see how they came up with a team of people that were that were their primary job was to enforce this in the hospital, and as Dr. Zainab said, making sure that this is a continuing legacy. It goes beyond thinking, oh, one person is the lead now, so we'll do it as long as they're there. Hire people, hire an admin team that their job is to audit the surgical checklist. I mean, this is wishful thinking. I know there isn't necessarily resources for these kind of things, but if it can be scheduled into people's jobs to make sure that this is a longer lasting legacy than just thinking it's a one man job, perhaps we will see sustainability. Thank you.
Thank you very much. I don't know if Dr. Adisa, or if I'm wrong, maybe Professor Adisa by now wants to come in.
Thank you, Mukhtar. Aurea said it. I personally think, what do we take home from here today? What do we take home to our different hospitals, particularly for those of us in Nigeria? The checklist is probably the most basic step to start enhancing safety in our practices. Nobody is saying that if you're doing a checklist and there's no pulse oximeter, then don't operate the patient. That's not it. And I think I mentioned it along the line that if you do a checklist and you see that it helped you to identify this deficiency, this problem, then the onus is on us to then rise up and correct that. But adoption of that checklist and removing the barriers to its adoption, I think is probably the take-home message for all of us here today, that we should ensure that this is done in our different practices. Thank you.
Thank you very much, and thanks all for keeping to time. Zainab, I don't know whether you want to say a few words before we wrap up.
I'll just say once again, thank you very much for all you're doing at the CMF Foundation. Thank you to all the speakers. And for those who are in Nigeria, let's continue to push. One day we'll get there and we get to recruit people to follow us in this effort to make surgery and healthcare generally safer for Nigerians. Because think about it, one day it could be us on that operating table or in that situation. Thank you.
Absolutely, and I think an important point, even for those of us who have the benefit of one of the best health systems in the world, the NHS, we have our relatives are still in Nigeria. Our friends, some of whom are here today, are in Nigeria. We visit Nigeria ourselves. We've seen, stories of wealthy Nigerians who went to their village where they never built a hospital and had a gastric bleed and died. There was a governor, some of you would remember, a few years ago, who had just been re-elected, and he had a bleed, he had a duodenal ulcer bleed, and died before. They were trying to rush him to Abuja because even in his state capital, there wasn't an endoscopist who could save his life, and he died. But unfortunately, we don't seem to learn these lessons that, absolutely, as Zainab said, even if you don't do it for others, do it for yourself, because it could be you or somebody very close to you. Femi, do you want to say some words in closing? We've got a couple of minutes. I don't know.
I just want to thank everyone for joining us today. It's been a very interesting and very educative session, to be honest. Thank you, Professor Adisa. Thank you, Dr. Ore Bajomo. Thank you, my very good friend Zainab. And thank you, Dr. Shobade and Grace. We appreciate every one of you for being here today. Everyone, we have about 34 participants now. Yeah, I think we had 35 at some point. Someone lost a signal. So thank you, everyone. We're going to make sure we finish at 9 prompt. And then I think Sadia, she's still on there.
Yes.
Sure. Excellent. So we've said it again, we want to collaborate with people. Concerned Medics Foundation is the way forward now. We want to have people from different fields of medicine, allied professionals, not only doctors, to join us so that we can push the narrative forward and make significant impact in the lives of our people back home and all over Africa. Thank you, everyone. We're going to log off now. Thank you.
Thank you, everybody. Thank you.
Bye-bye.
Bye.